many of us have worked on teams, whether they be in a healthcare setting or school-based or many other places that host teams. And sometimes we're just sitting there and we're not really communicating or being a cohesive part of the group. We're thinking, come on already, let's stop this. I heard enough of this already. And what we're going to talk about today is ways to make teams, more cohesive, more productive, and ultimately to benefit the client or the patient, in this case, older veterans. The session objectives for today are to describe variations of interprofessional healthcare teamwork, to use successful team-based solutions to guide team members in meeting the needs of the patient. We're going to talk about the roles of team in the VA PACT model, and finally talk about developing strategies to foster productive collaborations with other team members. I should say at this point that we tried to make this an interactive presentation to some degree. It's not always the easiest in webinars, but I do have a video embedded. I have a handout, and I have 3 more polls. When we get to the video, I'll show you where the handout is. But first, let's review the evidence for teamwork. And I don't have the time in this relatively brief presentation to give you all of the evidence. I really researched this quite a bit in my career, and there is a mounting body of evidence about the effectiveness of teams in many settings, including healthcare. I'm going to just give you a snapshot of a few studies that provide evidence about team effectiveness. Lemieux, Charles, and McGuire several years ago reviewed the team literature over about 20 years, and looking at 36 studies, they found mixed evidence. In fact, most team versus non-team interventions are in our VA system. We do have a long history of teamwork, as we all know. And these studies found that geriatric teams led to higher functional status, better mental health, and decreased dependence and mortality. Another study was conducted by Rubenstein in 2004, and he and his colleagues found that studies of clinical and cost that teams found that patients were helped by an initial assessment by multiple disciplines. And then in the third study that I'm citing, 26 programs for all-inclusive care for the elderly were assessed, and it was found that team performance was significantly associated with better patient outcomes. So they were able to look at the team dose, so to speak, in those 26 different PACE settings and did find better outcomes depending on the effectiveness of the team. There have been several qualitative studies, which I'll refer to now, and they point to the fact that team members really do need to know and trust each other for team effectiveness to occur, for teams to be cohesive. McCallan found in a qualitative study of 44 participants that when interdisciplinary practice is well established, members tend to have a more cooperative attitude and more positive interactions. Similarly, Long, in a qualitative study of team members' understanding of teamwork, found that after a 3-day workshop, the more hierarchical attitudes and lack of role understanding were reduced, that the time spent together in the 3-day workshop helped the participants return to work better prepared and work a more cohesive and effective team. So this webinar is geared to primary care practitioners, and particularly in rural settings. So I wanted to highlight some of the benefits of teamwork in the primary care setting. First and most important, it improves patient care. We have to remember always that the patient is always at the center of the team. Teams can reduce duplication of services, costs, assist in transitions. One important transitional issue is medication reconciliation when patients move from setting to setting. Teams, because of the collaborative nature of successful teamwork, help promote creative solutions to complex problems, which are, of course, more commonly found in older patients. A good team pulls in family and friends and even neighbors into the team, into the collaborative decision-making process in care plan development. Teams can help distribute workload and overburden practices. For instance, I'll talk about the PACT team model a bit later. In that model, the primary care practitioner can rely on other members of the team's other teams to reduce his or her workload. And finally, teams can enable providers to work at the top of their licenses. This is a key tenet in the PACT teams. As I said, we're going to talk a little bit about that later in the presentation. Now, over the years, there have been a number of definitions of teams that have been bandied about. And again, I don't have the time to get into long discussions about each of these types of teamwork. But, traditionally, the disciplinary team reigned, and that would be, a team of physicians, a team of nurses, and so on. And over the years, we moved to the multidisciplinary and then into the interdisciplinary teams, and now there's a new form of teamwork referred to as transdisciplinary. I'm going to talk a little bit about the differences between multidisciplinary and interdisciplinary teams because I do think that there can be confusion amongst these two types of teams. Often we think we're working interdisciplinarily when in fact we're not. We're really stuck at the multidisciplinary team level. In that type of team, the members work side by side. True collaboration is minimal. There can be layering of chart notes, orders, and meds, so there's an additive effect rather than a true collaborative sharing. Members always function within their discipline and not often to the top of their license. So oftentimes the patients and the clients may suffer because there is uncoordinated care that's delivered sequentially or in a layered fashion. When we move a group into the interdisciplinary mode of work, we often see some of these hallmarks. One are common goals and protocols which are agreed upon by the team members. There's shared responsibility in decision-making. There is not an autocratic decision-making modality, but there is true consensus. All disciplines are involved in the consensus, and communication and collaboration is open, it's easy, and it results in positive role overlap and sharing. And at its highest functioning, interdisciplinary teamwork may be considered transdisciplinary. And this is a concept that's come out of nursing and actually child development where there is team sharing amongst disciplines or provider categories within limitations of scopes of practice. There is a lot of back and forth with these terms. It gets a little muddy. So, not all groups are teams. We all work in groups which are collections of people, which often can be accidental. And so a working group can be dominated by a strong leader who might be somewhat autocratic in his or her style. The main purpose is usually in alignment with the organizational mission within which the team operates. Individual work products are produced, meetings are quick, they're efficient. It's kind of a discuss, decide, delegate operation. So what we want to talk about here is a focus on how we move a working group to a team. And it's really a movement from people working in a parallel fashion to full engagement of all team members. There is a sharing of leadership. There is both individual and mutual accountability. And it does require a commitment from the members to be a collaborative team. And there also needs to be effective leadership. And this ties into Dr. Chernoff's talk of last week, or last month, I should say. Well, that was in March, correct? Ronnie?
It was what?
It was April 6th. It was last.
Oh, it was April.
I have another poll here. For those who participated in Dr. Chernoff's webinar on leadership, you'll remember that she talked about 3 common leadership styles: democratic, authoritarian, and free reign. An authoritarian leader is one who tells his or her team members what they want and how to do it, whereas a democratic leader involves his or her team members in decision-making. The third major category is free reign, and these leaders allow team members to make the decisions. They do not provide any leadership direction. So at this point, I'd be interested in you self-assessing where you feel you fall in these leadership categories. I think this will just make a little more interactive. Is there anything you'd like to say briefly at this point, Ronnie, in a minute or less, while people still at the polls?
While they're at the polls? No, but one of the points that we made in the last webinar was that a really effective leader uses all 3 styles intermittently, depending on the situation and what will work in for that particular issue or problem, and so it's not unusual for an effective leader to be all of those things, but not at the same time.
Right. Although usually we do have a predominant style, wouldn't you say?
Yes, I would. But a really good leader knows when to change that style to fit the situation.
Okay. So, any other votes here? Okay. So we see that at this point, those who choose to vote, almost 3/4, identify themselves as a Democratic leader, which, I think we would want to think that I guess we're democratic in our style and not necessarily authoritarian. And about almost a third have checked other. That might be an amalgam of those 3. I'm not certain about that. We could talk about that later if you would like. So at this point, I'd like to move into some of the key elements that have been identified in building teams in primary care. And these elements are derived from an excellent book, Improving Primary Care, Strategies and Tools for Better Practice, that came out a few years ago. It's written by Bodenheimer and Grumbach. It's very good. I would urge you, if you're interested in this topic, to check this out or to buy it on Amazon. And they identified the need for defined goals, not only an overall organizational mission, but specific measurable operational objectives, because without those, you cannot define success of your teamwork. Systems are important. In the VA, we're lucky to have CPRS. Systems help us track the data, the outcomes, and the effectiveness of our processes. Task definition, division of labor, role assignments, and responsibility is another key component. Excellent training for roles on the team, and also cross-training so that team members can substitute for others in emergent situations or for planned vacations, for instance. And finally, communications protocols and structures. Bodenheimer and Grumbach's model really provides the foundation for PACT training. And I'm going to ask you now, how many of you are familiar with PACT training? And how many, this particular poll asks you how many have participated in the Patient-Aligned Care Team PACT training. I'm going to check out yes, and I learned a lot from it. I'm actually a trained faculty member in PACT for VISN 3. And I know that it's being rolled out a little bit differently depending on your VISN throughout the country. And some of you have had it and some of you haven't, but it is a secretary's mandate at this point in VA. Okay, so I see here that you're going to put, it's it's going up. It's going up. We don't have everybody doing the poll from the attendees that I see at the top of the screen, but it looks like, a third of you who voted have had PAC training, and 2/3 have not had the PAC training. So I'm going to tie this presentation at this point to the VA PAC model because it is particularly relevant within the VA. Of course, this is a VA-sponsored webinar. Let me go back to the content here. So in the PACT model, there are seven principles that drive patient-aligned care model, and they're patient-driven, team-based, efficient, comprehensive, I'm just going to read it at this point, continuous, an emphasis on communication, and an emphasis on coordination. Okay, these all make sense, of course. Some of you may have seen this schemata of the PACT teams. You see the primary care team is a large circle. The teamlet is in the middle. The teamlet consists of four individuals with specific position descriptions. The primary care provider, the RN care manager, the clinical associate, who would be a varied background in nursing, and then the clerk. And then the larger or the expanded team is around on the outside, and that includes non-VA care, hospitalists, and specialists, for example, and also you see the family and the community out there linked in as well. So I described the teamlet, which is on the left of this slide. The team, draws on all of the specialty disciplines, mental health, other VA programs, social work is, to me, amazingly not part of the teamlet. As having a social work background, I would have hoped that a social worker would be in the teamlet. For those of you who maybe perhaps work on PAC teams, you know that the teamlets are huddle. That's a new word now. Huddle on a daily basis just to catch up, usually at the beginning of the day, to see what needs to be done. Whereas the larger team, the expanded team, generally has a sit-down weekly meeting. Now, some of you may have participated. It was a very interesting webinar several months ago sponsored by HSR&D, and it talked about the team development measure, and it's something that I have studied a little bit, and I find that I like the approach and the self-assessment. The team development measure is really useful for identifying ways to improve the teamwork. And you can see that the conceptual model is 8 stages, beginning with the pre-team and working all the way up to a fully developed team. So at the bottom, you would have what would be called an accidental team, and then you work through, building cohesiveness, communication, role clarification, and then when all team components are in place, you would have a fully developed team. Here you can't really see the team development measure, but I wanted you to get an idea of the 31 items. In the 31-item scale, each member spends about 10 minutes to complete the questionnaire. And then this leads to a meeting of the group as a whole to discuss strategies for improving team development based on the self-assessment of each team member on these 31 items. Whereas this instrument can be used at any point in the life of the team, it's recommended that it be used in the beginning of team formation to encourage optimal teamwork. At this point, I thought we would mix it up just a little bit, and I'm going to show you a DVD of Mr. Rosario. This was developed in a GIT program, the Geriatric Interdisciplinary Team Training Program, funded by the Hartford Foundation, beginning about 15 years ago. And in this particular video, as it says on the side, 4 members of the healthcare team are assembled for their weekly meeting to discuss this patient. He's an 81-year-old white male with adult-onset diabetes who lives alone. So after viewing the DVD, or I actually should say while viewing the DVD, think about the effectiveness of the team meeting. And so I'd like you to go to up in the corner or up at the top, you'll see a little, like 3 little pages. It says handouts. Okay. This is a handout right here. I have to go to content. It's right here. Okay. So you'll see that the observation tool goes over team goals, professional roles, the organization leadership, cohesion, and communication and outcomes. So if you're able to download it, that would be good while you're viewing the video. If not, it's up on the screen right here. So now I'm going to go back. I'm going to play the video for you.
You are about to view a 5-minute video of a simulated team meeting. At the end of the tape, you will have 10 minutes to answer 5 questions. Questions will focus on team members' behaviors and the effectiveness of the team in meeting the patient's needs. Please print your answers and do not use abbreviations. 4 members of the healthcare team are assembled for their weekly 8 a.m. meeting. The purpose of this meeting is to develop a plan of action for the clients discussed. Present in the meeting are Andrea Brown, the social worker, Mary Thomas, the nurse practitioner, Simon Wilson, the pharmacist, and Jennifer Rogers, the internist.
It's 8 a.m. Let's get started. Does everyone have a list of the patients we're reviewing today? Okay, the first one is Henry Rosario. Mary?
Sure. Yeah, Mr. Rosario is an 81-year-old white male with adult-onset diabetes. He lives alone in a 2-story walk-up. Now, he's unable to control his blood sugar with diet alone, so he takes tolbutamide, 250 milligrams twice a day. He's been taking his medication as prescribed for the past 6 months. So far, he seems to be in good control. His diet's iffy. He has a sweet tooth, and he lives on junk food, despite my repeated instructions about his need to change his eating habits. His eyesight's been declining over the past year. It'll probably continue to decline, but so far he's able to do things like read his medication label, get his key in the door. Basically, he sees well enough to be safe at this time. He'll be coming in for some routine blood work, and I've scheduled a visit with the podiatrist to look at his feet and cut his nails. Yeah, I'm sure he'll be
Well,
fine.
why are we discussing this patient if he's stable? I mean, you know, we all have a lot of work to do, and our time is limited. You know, we need to set some ground rules about these meetings if we're going to get anything out of them.
Dr. Rogers, I've listened to your presentations no matter what you choose to focus on. The information I'm presenting is very important. It is exactly what we agreed should be the content of these team meetings. I'm saying he's stable now, but he's likely to be at risk for accidents and hyperglycemia in the future. And since everyone here may see Mr. Rosario over the next few months, I think this presentation is highly relevant.
We're supposed to present cases that seem complicated or require the input of others. Those are the ground rules. Was there something specific about this case you wanted us to review? Should I talk to him about his declining vision or other supports he might need?
Yeah, sure. I'll tell him to contact you when he's here later today.
What about medications? Is there some medications Simon should review?
Yeah, I'm interested in the tolbutamide. Is there anything else he's taking?
He's also taking Tylenol, 650 milligrams for some mild arthritis. And he takes Dalmane, 30 milligrams for sleep. Sometimes he repeats it.
Dalmane? Dalmane is a terrible drug for geriatric patients. He shouldn't be on Dalmane.
Really? Well, he's been on Dalmane for the past 30 years.
He hasn't been a geriatric patient for 30 years,
Well,
has he?
Simon, perhaps you can offer us another suggestion, another medication, a
Okay.
different dosage. You know, sleep problems in the elderly are quite common.
Yes, I know. I'm just surprised you don't know more about sleep medications. I mean, Dalmane can really be a problem because it's got very long half-life, at least 2 days. And this potentiates problems that all the hypnotics bring about, hallucinations, agitation, changes in memory and gait. Now, Benadryl is what I would recommend. Benadryl in small doses, 25 milligrams, can be very effective, doesn't have too many side effects, can be easily. Now, it does have some anticholinergic problems, but we can...
I think, Simon, we all
that.
think very carefully about sleep medications in the future.
Well,
Just trying to...
do we know the history of the sleep problem? I mean, maybe he doesn't need it anymore and he can be tapered off in time. Or perhaps it's sleep apnea that's waking him up?
No, it doesn't sound like sleep apnea to me.
It sounds like you'll work on the sleep problem, but I'm very concerned about his nutrition. It sounds like to me he needs a nutrition consult. I wonder if he can even carry groceries up those 2 flights of stairs.
I've tried to get him to change his eating habits. He's just not compliant. Maybe a nutrition consult will help. Will you go ahead and set it up?
Oh, I have a very busy day today.
Well, so have I.
But if you can't get to it, I guess I can. Anything else about Mr. Rosario?
Nope.
Good. Let's go on to the next patient. Judith Lichtenstein.
Okay. So, you can see from the video that there were, some challenges in the team communication and team cohesion. I think some people aren't muted. If you could perhaps put on your mute, I'm hearing some background noise. I mean, the team did have a goal, and it did have an outcome for Mr. Rosario, but getting there was fraught with, some lack of civility and respect and some behavior that was a bit off-putting. We don't have time to process the observation tool, which I often do in a face-to-face session, but you can do that on your own. So, next, I'd like to move on to it's two ladders together, and this has been used in team building exercises in the PAC team sessions. And I like that. It's an interesting team diagram in that it demonstrates the push and pull of effective teams. Because on the ladder on the left, you have relationships. You have the relationship side, so important, civility, psychological safety, all leading up to cohesiveness. And on the right side, you have the functions, the functions of a team where you need to get to go. And this tension between relationships and functions is common and hasn't always been properly addressed in talking about teamwork, in my opinion. And so it will provide the basis for the rest of my presentation. Basically, team challenges and how to deal with them. Now, the first three components, cohesion, communication, and role clarity, are steps in the ladder that I just showed you. Transitions and phases are also two other challenges for teams, and I've identified them as well as areas that I want to briefly address today. In the PACT training that some of you have had and others may have in the future, transitions is a significant topic of discussion. So the first challenge of the 5 that teams run into is cohesion. Civility, respect, and safety are really building blocks of team cohesion. If the members don't feel safe in the meeting and with their teams, then the teams are going to run into constant trouble, as demonstrated in the Mr. Rosario video. So deciding on ground rules, norms, and protocols, how meetings should be run, are paramount importance. Sometimes teams decide if there's a designated meeting facilitator or coordinator, or if this function should rotate. It just depends on the culture. Ground rules about behavior, cutting off people in discussions, raising voices need to be discussed, all toward the goal of open and balanced discussion. Now, how do we deal with cohesion issues? Some teams find it useful to send an agenda out prior to the meetings, although this is not always done. Brainstorming methods are helpful, and I'll talk about that a bit more in a minute. Reviewing the ground rules from time to time and revising if necessary. For instance, perhaps it turns out that maybe you need to rotate the facilitator or the convener, but you really need to have a check-in every so often about how the team is functioning. Process reviews are helpful. I'll talk about that a bit more. And then just getting to know each other through social activities such as potluck, after work, picnics, and so on. Now, brainstorming methods. I think most of us probably participated in those. They're not random. It sounds, we're going to brainstorm. But it's not a random activity. It's a structured process. And in this process, the members of the team define and agree on the objective. They brainstorm ideas and suggestions. Often there is, a sticky pad up on the wall, and people, walk around and jot down their ideas. So it does need to be managed. There are many ways of doing that, flip charts, whiteboards, different colors of pens. Then there needs to be an assessment or an analysis of what's come out in the brainstorming, perhaps of ranking or prioritization of some kind. Then the team members, in a democratic fashion, have to agree on the actions and time frame for what has been decided by the group. And, of course, there does need to be follow-up. So that is kind of a brief outline of a brainstorming process. Now, process reviews are used in industry and education, healthcare. It's tied in with QI. And in a process review, you would, for instance, if applied to a healthcare team, you would have team members take turns. This would rotate, following a checklist periodically. And this checklist could include items such as, the team's fidelity, the team objectives, ground rules should be reviewed, discussion as to whether there was an agenda presented, whether the members could speak without interruption, whether time limits were honored, and whether task assignments were agreed on by everyone present. I'd like to remind everybody to please mute. Again, I'm hearing some rustling of papers. That is a little... Okay, thank you. Okay. I have a checklist for team process review that I didn't put up, but I could certainly share with you. So the next challenge is communication. Open communication is key. Conflicts need to be handled as calmly as possible. There needs to be a pre and full discussion before decisions are made. And the psychological safety will, result in honest and truthful discussions and discourse. Communication is certainly enhanced by modern technology, up-to-date record systems, such as CPRS, regularly scheduled meetings that start on time, end on time. And also, there needs to be at least one person on the team who's an effective liaison with the larger system, and that could be somebody who reports directly to the head of nursing, the DON, or to the chief medical officer, or to the facility director. so that there is a way of, being able to communicate openly and coordinate the team's objectives with the larger organization's objectives. Dealing with team issues or communication issues we talked a little bit about this before. I won't go over all the points here in the interest of time, but often teams will bring in an observer or a coach, or even a mentor, you could call the person, to watch the team and give feedback. I have done that before. It's best not to have an internal individual do that, somebody who's neutral, who can help the team, work through some of their communication issues. I think testing for agreement and decisions, making certain that everybody is on board, and that takes some skilled leadership at times. And then, using the data. I mean, decisions, need to be data-driven to the greatest extent possible. So if there can be data at the table, this will help with communication. The third challenge that teams often face is role clarity. Now, in an ideal world, team members could have, formally, designated roles, and it would be clear of what everybody was doing. It doesn't always happen that way. There's a lot of overlap of position descriptions and disciplines, and I guess that's kind of the downside of transdisciplinary work. But that being said, there needs to be an understanding of, generally the scopes of practice, and as well as what roles can be shared. The team also needs to feel, and every team member, that what he or she is been tasked to do is workable, so people aren't feeling burned out and overloaded. And then coming together to plan on work schedules is very important. When teams run into problems with role clarity, there needs to be a discussion about assignment of roles. It's not always possible to change roles. I mean, we just can't decide we're going to do something else, but I can tell you that out of the PACT training I participated in a couple of weeks ago, the facility decided to change the title of, at least locally, of the RN clinical associate, and to talk about some slight nuances there. So if you can empower team members, within limitations of the system, to adapt their job descriptions, that is indeed empowering. An excellent team leader will periodically clarify, discuss team roles and expectations in a group meeting, and I think this goes to Dr. Chernoff's point that, a democratic leader is great a lot of the time, but sometimes you might need to be a little bit more autocratic in terms of what needs to be done and how it gets done. And, I do think that there needs to be, again, that environment of psychological safety so that folks feel able to question actions and to question roles in an open and honest way. The fourth challenge that I'll talk about briefly are the transitions issues. Now, this is a huge body of work. It's a very big topic now. I really can't, obviously get into it in great detail. But this is where so many patients and clients fall between the cracks. It's in the transitions. The handoffs are inefficient. We get into problems with, medications not being properly transferred from place to place. And so, there are new decision makers, there are new teams, you have to negotiate the VA and the non-VA systems, and I think it's well documented what poor transitions can lead to, medication errors, stress, death, I won't go into all of the negative outcomes, but there are myriad. So how do we deal with transition issues on a team? Well, obviously, I think you need face-to-face meetings. You can't, distant means, just reviewing charts, electronic charts, blinded emails, just are really, a setup for disaster much of the time. You need to have collaborative working relationships with other teams, both in your institution and out of your institution, whether, if you work with community-based hospice, if you're in the VA, you need to have those face-to-face meetings. I know that we do that here at the Bronx VA. And then the communication around admission, discharge, test, meds, and follow-ups. Those are real error-prone points in the transition chain. And keeping family in the loop, of course, is essential to ensure a smooth transition. The last challenge are the team phases. You may have heard about these phases, and they're not fixed. It's not like you go from 1 to 5 and you stay at 5. Teams are fluid. This came from the work of Drink and Clark, and it's been in the literature now for, well over 20 years. And, you see it here. You have this formative stage, the norming, where everybody kind of gets into the culture of the team. Sometimes there's a confronting stage, also known as storming stage. They're called storming and confronting are both used. Performing stage, and then leaving is when folks, retire, go to another work setting. I think we always need to remember that there is always head turnover. Students come, residents come, social work interns. Teams have a lot of new folks coming and going, so we should never take anything for granted. We've got to make certain that those folks are introduced and feel comfortable in the culture of the team. And there are a number of ways to deal with transitions. And oftentimes a coach or an outside observer is brought in when teams are having problems in terms of performance in the storming phase. And I think an outside facilitator can help with an open discussion. Again, we have to remember that rituals are important. So palliative care teams start with a ritual, reading a poem, for instance. There are many ways to establish the particular culture. So at this point, because we want to leave some time for discussion, question and answer, I'm going to review the take-home points from my talk. Teams are not accidental. They obviously take a lot of work. Healthcare teams are quite varied in their structure and processes, and if you've seen one team, you have really seen one team. It's not just something that's inherent. Having some explicit knowledge and having some skill development about working on teams is quite important. There needs to be ongoing work on team maintenance. It's just, you can set up a team, but it's, things happen along the way to challenge the team, as I have outlined in those 5 common obstacles. And finally, managing team dynamics is the responsibility of all team members. I just wanted to tell you a little bit about a pilot program out of the Geriatric Scholars Program, which is which is sponsoring this webinar. Dr. Josie Kramer of the West LA VA obtained funding from the VA Office of Rural Health for the Geriatric Scholars Program over 3 years ago. And now in our rollout this year, in this fiscal year, we have a new component called Rural Interdisciplinary Team Training, or RIT, and we're piloting some team training at community-based outpatient clinics in rural settings. We have most of our pilot sites lined up for this training. We still have potentially 1 or 2 openings. If you're interested, please contact me directly at my email,